Hello, this is chapter 23 review. This is all about the spirochetes. These organisms really fascinate me. I think they're really neat how they move. They cause some interesting diseases, and they're interesting, very interesting to me. So let's delve in. So spirochetes. In general, the order Spirochaetales contains two families. These two families are the Leptospiraceae and the Spirochaetaceae. So of the Leptospiraceae family, this contains the genus Leptospira. And then in the Spirochaetaceae family, it contains the two genera Borrelia and Treponema. So we're going to talk about all three of these genera. But let's talk about a little bit more general information about the spirochetes. So the spirochetes are the causative agent of important human diseases and zoonotic diseases. They're slender organisms. They're helically shaped bacteria. They have flexible cell walls. They have fibrils known as periplasmic flagella that are responsible for their motility. They're gram-negative, and the genre of Leptospira reproduce by transverse fission, whereas the genre Borrelia and Treponema reproduce by binary fission. So interesting. So let's talk about the first of the three genera, the Leptospirs or Leptospira. They are tightly coiled, these organisms. They may look like a chain of cocci because they're so tightly coiled. One or both ends have hooks rather than tapering off. And there are two particular species in this genre that I want to talk about. And the first one is Leptospira interrogans, and this is pathogenic. And then there's the second one, which is Leptospira biflexa, and this is a saprophyte, which means it gets its energy from and nutrients from dead or decaying organic material. Leptospirs are obligate aerobes. They can be grown in artificial medium, two of which are Fletcher's semi-solid medium and Stewart's liquid medium. All species have two periplasmic flagella, and I'm just going to give you a hint that when differentiating these different spirochetes, an important consideration is the number of flagella that it has on, in its periplasmic field. So this particular genre, Leptospirs, have two periplasmic flagella. And these are not visible by bright field microscopy. So that's another important factor when distinguishing or determining which organism you have, is whether you can see it or not in bright field microscope, under the bright field microscope. So this one is not visible under the bright field microscope. You can only see this under dark field or phase contrast or with an electron microscope. These creatures, spirochetes, remind me of my hair. They look like what my hair looks like, little tiny coiled ringlets. The disease that the genre Leptospirs causes is leptospirosis, a zoonotic disease in humans primarily associated with occupational exposure to rat-infested surroundings, fish and poultry processors, or even sewage workers. In the U.S., the majority of cases result from recreational exposure, and usually commonly in the summer. In the natural host, this is an important note, Leptospirs live in the lumen of the renal tubules and are excreted in urine. So this is an important note you need to know, that in the natural host, they live in the lumen of renal tubules and are excreted in urine. So dogs, rats, and other rodents are primary reservoirs, along with squirrels. A host, such as you or I, can acquire an infection by contact with infected urine or urine-contaminated water. Most likely, leptospires enter into our bodies through breaks in our skin or our mucosa. There's quite a lengthy incubation time. It can be 10 to 12, that's the average, 10 to 12 days of incubation. That can be anywhere up to 30 days. Onset of this particular disease usually is abrupt with flu-like symptoms. Often the result will be renal, hepatic, and CNS involvement, or central nervous system involvement. If left untreated, you can develop something called Weil's disease, and this is a severe systemic disease, including renal failure, liver failure, and intravascular disease, sometimes resulting in death. So under the microscope, Leptospira genera, it is possible to directly see them, but not recommended for detection. Visualization is only successful in a small percentage of cases. Leptospires can easily be cultured from blood or CSF during an acute phase of the disease. After the first week, leptospires may be shed in urine, which can also be cultured. We usually treat leptospirosis disease with penicillin if given before the fourth day of infection. Doxycycline is another alternative. Vaccinations are available for humans in endemic areas and also available for dogs and livestock. So that's good. That's a good thing. Let's talk about the second genre of spirochetes, and this is Borrelii. All Borrelii are arthropod-borne. That's an important fact. Arthropod-borne. Most species of Borrelii cause relapsing fever. They're gram-negative and highly flexible organisms. They stain fairly easily. They can be seen under regular light microscope. So this is the only spirochete you can actually see under light microscopy. This genre has 15 to 20 periplasmic flagella per cell. And this particular genre is easily grown in the lab using something called Kelly medium. There is a particular species called Borrelia recurrentis and similar Borrelii species that cause relapsing fever. So with this particular disease state and organism, you'll have these febrile episodes that subside and then tend to recur over periods of weeks. The relapsing fever is due to antigenic variation. So as it is growing and living inside your body, its surface antigens are changing, thwarting your immune system in the host response. So once your body thinks that it's made a specific antibody, mass-produced antibodies, and has attacked the organism, this organism will change its antigens on the surface of its cell, and then your body has to start all over again and recognize it as foreign and create new antibodies to that new antigenic variation. So this is what causes that relapsing fever. Infection Incubation period is 2 to 15 days. Infection causes massive spirochetemia. It's also accompanied by these high fevers, rigors, severe headache, muscle pain, and weakness. These febrile periods will last about 3 to 7 days and then end abruptly once your body has made a good immune response to that particular antigen. And then it'll start all over. Disease reoccurs several days to weeks later, usually following a less severe but similar course. So 2 primary relapsing fevers caused by Borrelia recurrentis is one tick-borne, and the second one is louse-borne. That first one, tick-borne relapsing fever, is considered the endemic relapsing fever, and this is transmitted by Ornithodorus ticks. They're little red-brown ticks, and transmission is made by infected saliva during tick attachment. And then the second relapsing fever type is the louse-borne relapsing fever, and this is considered epidemic relapsing fever. And this is transmitted by the body louse. Pediculus humanus is this particular species. And this is disease is transmitted when infected lice are crushed and then rubbed into the skin. So maybe itching your head, because you can, head lice can carry this as well. So maybe itching your head might crush those lice, and you might have a scab. So if you open that scab or wound, you can, it can allow the spirochete inside that louse to enter your body. So laboratory diagnosis of Borrelia recurrentis is made with Wright or Giemsa stained on blood smears. So you can see this on a blood smear. It's the only spirochete disease, borreliosis is the only spirochete disease in which organisms are visible in blood with bright field microscopy. So the appearance of spirochetes among the red cells is characteristic. I mentioned something about Kelly medium. You can grow this on something called Kelly medium, which is a combination of bovine albumin, 7% gelatin, and serum. And because these organisms have this antigenic variation, it's difficult to serologically test for them. It makes it impractical. We treat Borrelia recurrentis with tetracyclines. That's our drug of choice here. Let's see. But the best thing is to prevent and control arthropod vector exposure. So when you're out in the woods, it's important to maybe put some kind of a bug repellent that includes ticks. You know, keep these away from your body. There is another organism of Borrelia that is called Borrelia burgdorferi, and this organism causes Lyme disease. I know most of you have heard of Lyme disease. It was first described in children in Lyme, Connecticut in 1975, and this is where it gets its name from. It is transmitted by Ixodes domanii, which is the wood deer tick. And usually we see these increase or infections of this type increase from June through September because people are outside. They're in the woods being active. Lyme borreliosis clinical infection includes fever and a headache, muscle pain, and even fatigue and weight loss. About 60% of patients exhibit erythema chronicum migrans, or ECM, and this is the characteristic skin lesion at the site of the tick bite. This is your bull's eye rash. that goes with Lyme disease. Late manifestations involve the joints and cardiac and neurologic systems. And arthritis is the most common manifestation, occurring weeks to months later after the infection. Culture permits definitive diagnosis, but usually we diagnose this supported by serology testing. Doxycycline and amoxicillin are equally effective during the early stages of this disease. Ceftriaxone has been effective for treatment during the later stages. So kind of know that. And that brings us to our third genre of spirochetes, and this is Treponema. Treponema are fine spiral organisms, about 6 to 20 micrometers long. They're very difficult to see with light microscope, but can easily be seen under dark field microscopy. These have 3 periplasmic flagella, and they have pointed ends along with a sheath. They're motile and graceful in their movements when in liquid. There are 4 clinically significant species of Treponema pathogenic to humans. The first one is Treponema pallidum, subspecies pallidum. This causes syphilis. And then there are 3 others that we'll briefly discuss. That's Treponema pallidum, subspecies Pertinu. This causes yaws. The third species is Treponema coradium. This causes pinta. And then Treponema pallidum, subspecies endemicum, causes Beigel. So we'll briefly talk about each one of these. Syphilis, this is the disease caused by Treponema pallidum, subspecies pallidum. You acquire this disease through direct contact with someone who has an active primary or secondary syphilitic lesion. Genital organs are the primary sites of infection. It is a STD. You can also acquire this organism infection by non-genital contact with a lesion, or transplacental transmission to a fetus can occur, called congenital syphilis. And the natural course of syphilis has 3 stages: a primary, a secondary, and a tertiary stage. In the primary stage of syphilis, you have rapidly multiplying spirochetes that spread to lymph nodes and other organs. You'll have a primary lesion that develops 10 to 90 days after infection, and this is called a canker. Usually the lesion is clean with its boundaries. It's non-painful. It has a raised border, but it is full of treponemes and very infectious. Lesions may not be apparent in females, and there's seems to be no symptomatic signs or symptoms other than that primary canker lesion. The secondary stage of this infection, syphilis, occurs 2 to 12 weeks after the primary infection. It may last several weeks or be mild and go unnoticed. Symptoms include a fever, sore throat, lymphadenopathy, headache, and a rash that can be present on the palms of your hand and on the soles of your feet. These secondary lesions, if they develop on your body, are also very infectious. And then there's a 3rd stage or tertiary stage of syphilis, and this 50% of untreated patients will develop tertiary syphilis, and it can be anywhere from 2 to 20 years after initial infection. And with tertiary syphilis, you get these granulomatous lesions called gummas that form on the skin and even in the bones and the liver. There are degenerative changes in your central nervous system that can occur called neurosyphilis, and something called syphilitic cardiac lesions, which usually occur on the aortic, can be present. Patients in the tertiary stage are usually non-infectious, and we don't see very many of these in the U.S. I want to talk about something called congenital syphilis. Treponemes can cross the placenta and be transmitted from an infected mother to her fetus. Congenital syphilis is very severe and mutilating, and all pregnant women are usually screened for serologically for syphilis early in their pregnancy. So to diagnose these quickly, we can do a dark field microscopic examination, but this has to usually be done in the primary stage from a scraping of the skin lesion. It has to be done within 10 to 15 minutes from collection, and it has to be done by somebody who has extremely considerable skill and experience to actually identify this correctly under the dark field microscopic exam. So it's not practical in most laboratories. So there's some serology testing that we do for syphilis. There's 5 altogether that I'm going to talk about. There are 2 major types of serology tests. The one type is non-treponemal tests, which are basically screening tests, and then the second type are specific treponemal testing. So the 2 non-treponemal tests are designed to detect something called reagin. Reagin is an antibody found in the body that develops against lipids released from damaged cells. So these serological tests, non-treponemal serological tests, aren't detecting the actual organism. They're detecting an effect that the organism has had on the body. It's detecting reagin. They're not specific and can react with other organisms and conditions, but they're excellent screening tests. So the antigen that's used in is a complex of something called cardiolipin and lecithin, and this is made from beef hearts. So the first non-treponemal test is the Venereal Disease Research Laboratory Test, or VDRL. This uses the cardiolipin antigen mixed with a patient's serum, or CSF, on a glass slide. So when reagin, if present, reacts with the antigen, flocculation will occur, which is observable. It's an observable positive reaction and is read microscopically. The second non-treponemal test is the rapid plasmin reagin, and this is the rapid plasma reagin test. That's the RPR test. This is the most common non-treponemal test used, but it only uses serum, so you don't do this from CSF. So there's an antigen bound to carbon particles, and this is what this test utilizes. You read reactions macroscopically, and these are usually displayed as black agglutination. And if you have a reactive or weakly reactive sera, usually titers are performed. So, those were 2 screening tests. But there are 3 treponemal tests that are used to confirm positive screening tests. So, treponemal serological tests detect antibodies specific for treponemal organisms or antigens. All positive non-treponemal tests must be confirmed by one of these treponemal tests. These are helpful in detecting later stages infections, later stage infections. The first one is the fluorescent treponemal antibody absorption test, or the FTA-ABS test. In this particular test, a patient's serum is absorbed with extracts of cultivated treponeme, not treponemal pallidum, to remove any non-specific treponemal antibodies. So any antibodies other than treponema pallidum antibodies will be removed when it's absorbed. After absorption occurs, the serum is then placed back on a slide with treponema pallidum organisms that have been fluorescently labeled and fixed to the slide. So if there are specific treponema pallidum antibodies present, they will bind to the fixed fluorescent antigens that are on the slide, or organisms that have antigens on the slide. Non-bound constituents will be washed away, and then if there are bound constituents, they will be fluorescently labeled and detectable. The presence of fluorescent treponema pallidum organisms is a positive result. Second treponemal specific test for treponema pallidum is the microhemagglutination test. This is an indirect hemagglutination test for T. pallidum. Antigens are absorbed to tanned erythrocytes. It's less sensitive, but slightly more specific than the FTA absorption test. Excuse me. So the third treponema pallidum specific test is the TPPA test, and this is the particulate agglutination test. And this one has largely replaced the microhemagglutination test. This involves gelatin particles that are sensitized with T. pallidum antigens instead of sensitized red blood cells. Simpler to perform, requires less expensive microscopes, and is more specific than the MHA treponemal test. We treat syphilis with penicillin, pretty simple. However, there is a reaction that can occur after treatment called the Jarisch-Herxheimer reaction. And this is where there's a fever that develops and malaise and a headache. So just a note, this reaction can occur after treatment. There are some alternative drugs. Doxycycline and tetracycline are a couple of those. So there are 3 other treponemal diseases that I want to talk about. They occur in different geographical regions or areas of the world. All 3 diseases have a primary and secondary stage. The tertiary manifestation is uncommon. And these 3 other diseases are rarely transmitted by sexual contact. And congenital infections do not occur with these. The first one that I want to talk about is yaws. This one is caused by the organism Treponema pallidum subspecies pertenu. This is endemic in tropical Africa, South America, India, Indonesia, and the Pacific Islands. It's not seen here in the U.S. The course of yaws resembles syphilis. Early stage lesions are elevated granulomatous lesions. The second disease I want to talk about is Beigel, and this is known as the endemic syphilis. And this one is caused by Treponema pallidum subspecies endemicum. This one closely resembles yaws in clinical manifestations. This one's found in the Middle East and Central and Southern Africa. Its primary and secondary lesions are usually papules that go unnoticed, but they can progress to gumas on the skin, bones, or nasopharynx. And this one's transmitted by direct contact or sharing contaminated eating utensils. And the last little disease I want to mention is Pinta, and this is caused by Treponema caradium. And this is found in tropical regions of Central and South America, not here in the U.S. It's acquired person-to-person contact, rarely sexually transmitted. Lesions begin as scaling, painless papules, but progress to a rash that becomes pigmented with time. And that's all I have to say about spirochetes. They're interesting little gram-negative organisms that are coiled like my hair. Maybe that's why I like them. That's it.